This conference will now be recorded.
Okay, good evening, everybody. It is Rick, and I'm standing in for Len, and I have a public apology to make to Len. If any of you read the reminder, I cast dispersions on him, but I shouldn't have done that because I completely forgot I'd switched with him from the beginning of the month. So he didn't do anything wrong. He never does anything wrong, Len. And so I'm sorry. Um, just a quick word to our sponsors, who are Bayer, Johnson and Johnson, Telix, Foundation Medicine, Blue Earth, and who did I miss? Novartis. Oh, the big one, Novartis. Oh my gosh.
Myriad Genetics.
And Myriad Genetics. They won't be listening in. I don't think we're getting, I think we're losing Myriad, and I don't know who else. We could be losing a bunch of sponsors there. I don't know. I don't want to go there right now. Anyway, we have 1.5 new gents. One of them is Jim Aiken, who was kind enough to brief me. So in the interest of time, I will tell you what I know, but I will also say that there's a couple of additional questions we're going to ask Jim, which were not in the information. So just bear with me whilst I bring up Jim. Of course, that's the Jamaican. Okay. So, Jim lives between Nashville, Tennessee, and Bradenton in Florida, where we have a few other people in that area, like Len in the winter, and Bill Franklin, who's not on here, and Bob Schwartz, who is on today, and we have a few people. And he's 85. He found us through ASPE. Most of you won't know who ASPE is, but they are Active Surveillance Patients International, and they are an organization for people doing early active surveillance. Most of them are 3+3 or 3+4 people. And we also have 4 groups a month that support those people. Jim was diagnosed in 2008. So doing my math very quickly, he was probably around 67 or 68 at the time, but he can correct me. And he was a 3+3. So today we'd say, well, did he really need treating? We don't know, but he decided to get proton beam from Loma Linda Hospital in 2009. And from 2009 to 2019, his PSA was very stable. And then it started to move up. And by 2023, it was 1.5. And by 2025, it was 4.7. And a recent PSMA shows possible cancer within the prostate and in the right external iliac lymph node. And so Sam wrote to me, and he said his urologist is prescribing Orgovix and he's getting that through the VA. So he's obviously a veteran, Captain Jim. and I've signed him up for the veterans program, for the veterans group. He signed himself up for the veterans group. And let me just tell you, Jim, that may be a route paved with gold for you. It often is for many of our veterans. So that's what I have. I have a couple of questions, and then we're going to open it up to the group. I did say that we strongly feel that he shouldn't be with a urologist anymore, and given that he lives in Bradenton, we think that Dr. Guanciale would be a great option for him in Sarasota because it's not that far away. And there are at least 2 men that I can think of on this call tonight who see Dr. Guanciale. So you can ask them questions, Jim. My question for you is, what do you recall back in 2008, what your PSA was back then?
Well, I was on the, I'm trying to think of the drug I was on for enlarged prostate, PrCa. I think I was on PrCa.
Yes.
And of course, you got to realize that the PSA on the PrCa is half what it really is. So if you take away that PrCa, it was probably running around 5, and in 1 year it went up to 10.
Okay.
And based upon that, we did the biopsy of 12 samples, and 2 of the samples came back positive with cancer. And with that, I did my homework, studied all the options, and decided to go with the proton radiation at Loma Linda, which I did in August of 2009 for 10 weeks. It was a marvelous vacation. Enjoyed being in California. Of course, I was living in Colorado at the time, so going from Colorado to California in the summer was really a negative. But anyway, the prostate treatment was painless, as you all know if you've had proton radiation, and it stayed at a very low PSA for the next 10, 12 years. And when it started rising up in 2023, went from 0.7 to 1.5 in 1 year. I was at that time I was in Bradenton. We spent 6 months in Nashville, which is my primary home, and 6 months in Florida, which is Bradenton, or actually Anna Maria Allen area. And I was in Bradenton at the time when the prostate. I had a urologist there, somebody I didn't like. I didn't stay with him, even though he did all the initial tests. He did the first thing he did was what they call it.
So let me move you along just in the interest of time.
Okay.
We now know that you are scheduled to start Orgovyx, which would probably be our preferred drug.
It's the preferred drug of my urologist here. I have a very good urologist here with Vanderbilt Urology.
Mm-hmm.
Doctor by the name of David Pinson.
Oh, we know him. Yes, he is a good doc, but he should have let you go and moved you over to his GU medical oncologist. But we know that
he didn't. He did not let me know that. In fact, I informed him today that I just learned about that.
Yeah, well, Penson's one of those docs. There's 3 or 4 of them. Crawford's another, Shaw's another in the United States who like practicing with advanced prostate cancer patients, and it's a bit dubious. We don't think you get the best treatment, but Dr. Penson wouldn't agree, and he is a very, very reputable urologist, but he has been known to hold on to his patients. So
well, I informed he's hard to get to see because he's on the road giving speeches everywhere. He's out of the office right now. And when you told me about the GU need to be on a oncologist, I went to him. Of course, Vanderbilt has a great computer access system, and he's easy to get to, easy to send message to. And I informed him that I didn't tell him where I got the information because in the last week I've seen my veterans, my VA primary doctor, and I've seen a radiologist here in town, proton radiation radiologist, only for information because I knew I couldn't have that again. But he's a great doctor, and I highly recommend this guy if you're in the Tennessee area. And he spent 45 minutes with me telling me a whole lot of information I didn't know, wasn't aware of. Mainly, yes, I could have proton radiation again, but he didn't recommend it, and I wouldn't do it either, based upon what he told me. But when I learned from you about the need to have an oncologist, my first thought was to do it in Bradenton, but really I need to keep all my medical records on one site, which they are right now with Vanderbilt, with the Vanderbilt medical.
Well,
system.
I don't think that, personally, I don't think that should guide you. I think you can switch your medical records. And to be honest, I completely forgot about this, Gent. There is an outstanding radiation oncologist in the area, in the Bradenton area.
Yes, I know you have. But because we're in Nashville right now, out of curiosity, I did call Vanderbilt Oncology, expecting to get the biggest problem with dealing with Vanderbilt is you just can't get an appointment with any doctor over there in less than a couple of months. It's very difficult to see anybody. And I expected when I called the Vanderbilt Oncology, when could I get an appointment? She said, "Can you come in Friday?" I said, "Sure, I can come in Friday." I wasn't expecting that. So I am going to go see a lady doctor here at the Vanderbilt Oncology on Friday.
Schaefer? Who are you going to see? Schaefer?
No, her name is Kristen Ansell. Probably never heard of her.
Well, yeah, I mean, the doc I know is Schaefer. Did you make sure, let me just pull up because I've got them. Did you make sure that she was a genitourinary medical oncologist? I think she's on that list, but I want to look. Because you don't need to, it's no good seeing any oncologist. You got to see somebody who specializes in genitourinary.
Well, that's what I asked for.
That's what you asked for. Okay, well, I'll tell you, hold on a second, and I'll tell you if that's what you're getting, because I was looking at them again. The problem is that they don't really have anybody who's that experienced anymore at Vanderbilt. Hold on, urological cancers, medical oncology.
Rick, I'm coming up with nothing on a GU specialty for her.
Yeah, she's not a GU medical oncologist.
Okay.
Don't waste your time. The one who is Kerry Schaefer.
Terry Schaefer.
Kerry with a K.
Kerry, okay.
Okay, I'll put her, you know, if you asked if she was a GU med onc and they said yes, then you have to ask, well, why isn't she listed on your urological cancers medical oncologists? Because I don't see her listed on there. And we want to be sure that you are going to see one. I mean, I would say to you, as much as you want to get in, I would say see Guanciale and go see Sean Collins and ask Sean Collins if you're eligible for radiation, because he's one of the best in the country.
Where is he?
He's in at University of South Florida in the Tampa area. So, you know, that, and these are the sort of doctors that we would rather give you the opinion as to whether you are eligible for spot radiation or not eligible for spot radiation.
Well, like I say, this Dr. Gray at the Tennessee Center for Proton Radiation in Franklin, Tennessee.
Yeah, but you're not going to do proton this time. This
Well,
is it.
he's a proton and special. That's his center, the proton center.
Right. But
Uh,
proton centers want to do proton.
of course.
And that's the problem. We send you to somebody like Dr. Collins. He's going to be a lot more agnostic in telling you what's best for you and not telling you what's going to make him money. So that's why we're saying. But let's get on to something else. And I mean, please you know do it. These are only suggestions, but the other question that should come up is when the disease returns and it's probably in the lymph nodes, do you do more than Orgovyx? Do you do 2 drugs? And that's the question I'd like to put out to the group for your benefit tonight.
Yeah, I was not aware of the second drug. Pinson never mentioned the second drug.
Right. So who would think that if the disease returns, that the second drug is a possibility? My belief is that it's only abiraterone recommended. My belief is only abiraterone is recommended and not the Ide brothers, but I think that's the NCCN guideline. But let me throw it out. Jim Marshall, you got your hand up.
Yeah, Jim, do you have heart issues at all?
No, I have no. Only underlying issue I have, I'm borderline kidney.
Okay.
I'm very healthy for an
Okay,
85
no
year old.
problem then. No problem on the abiraterone then.
Okay. Any of my moderators want to jump in on this?
Oh, this is John. The only biopsy that we have is the 3+3. Is that correct?
That's correct.
So this new lymph node was diagnosed how, with a MRI or something?
PSMA.
PSMA.
Oh, a
PSMA.
PSMA. Okay.
Just
So
a month ago.
lymph node metastasis is the one on one side of the scale for risk, and on the other side of the scale is a very, very long, at first delayed and then very slow growing cancer. So without any further information like predictive genetics or anything like that, I think the risk is too low for a second drug. Although I think Rick is more familiar with the guidelines.
Okay.
Yeah,
Anybody else?
Rick,
Yeah.
I would agree with John here. At
Yep.
85, why not see
Yep.
if the Orgovyx by itself takes care of his single lymph node and relative. What's the PSA now, Jim?
Right now, the PSA is 4.7.
Yeah, I suspect if you just take Orgovyx, you'll drive that down to undetectable just by itself. Maybe you don't need a second drug at this time, even though the NCCN guidelines may call for it. There are Rick, I think other factors to take
Yep.
into consideration here. Yeah.
And
So
what
then
would
let's say that what we do what Len says, and 6 months from now, the PSA hasn't gone any lower than something like 0.2. Then maybe that would be a good indication for a second drug.
what would you say, Sam? I'll come to you in a second. What would the moderators say about spot radiation?
Good option. Certainly appropriate by guidelines standards.
Not very much risk either.
One of the lesions is close to the rectum. That was the concern from the Dr. At the Proton Center. He was very concerned about having that lesion so close to the rectum, and he certainly didn't want to create a problem there.
Okay. So that's the external iliac lymph node, which was the only one I thought that they saw. That's not close to the rectum, is it?
No, that's in the middle of.
So, I'm not sure that we're saying radiate the prostate, which is where the concern might have been. I think, the prostate will probably get handled with the prostate could well get handled with the Orgovyx. But the question is, what about that lymph node that's distant? And should we be focusing on that? And that's why I would like to see you talk to an expert radiation oncologist in a center of excellence. The guy that I've been impressed with at Vanderbilt is Austin Kirshner, and I'll put his link in. I've heard him speak. I think he knows his way around, and so he might be a guy to get another consult with. And then, like I say, if you were to opt for treatment down in the Bradenton area, you can't do better than Sean Collins. We've been sending people to Sean Collins for years and years when he was at Georgetown, but he moved about a year ago. He left Georgetown and he went down to South Florida, which is where his he's got a twin brother, and I think his twin brother practices down there as well.
Did you say Tampa? Tampa?
He's at the University of South Florida. I'm not exactly sure. I put the link in the chat window. Do you know? Let me tell you where the chat window is.
Orlando. The Orlando area.
So let me just tell you the two little boxes to the right of the 41 at the top is the chat window. And if you click on that, you'll see some links. And all you've got to do is click on those links and they'll open in your browser and you can look at them later.
Okay, good. I see that now.
Yeah, so you just click and you can open them. You can also download that with those three dots. It's always good to do that. But if you click on it, it'll open in the browser and you can check. You can check later. Dr. Jack seems to think that Collins is in the Orlando area. I'm not. I honestly don't know. I don't know. He's in Tampa, Florida. Two Tampa General circles. So he's certainly within striking distance for you.
Yeah, he's just an hour away.
Right.
That's easy to see. I can see him easily.
And he's really, really good. He knows AnCan. He may have forgotten us now, but he knows AnCan. He treated one of our board members. He treated another one of my own personal advisors. He's a super guy. And did he treat you too, Jim? I can't remember. Jim Marshall, did he treat you?
Negative.
Okay.
Negative.
But Jim knows.
I was already stage 4 and beyond that.
Okay, so well, it's not beyond that because he treats spot radiation as well. So he could have, he could be good for spot radiation. All right. Sam, you have your hand up. Please.
I just wanted to mention that I did a year of Erledo and Orgovyx as a result of my PSA being around 7.8, and was pretty well tolerated. And I started it the beginning of December, and by January 9th, my PSA dropped to 0.04, and my testosterone went from 523 to 6.
So
Uh,
did you have, I forget, I don't have your record, but did you have any activity in your lymph nodes, Sam?
I had my PSMA as a result of the elevated PSA in November of 23 showed that I had a new focal intense uptake within the small bilateral hilar nodes, lymph nodes.
Okay. And
And
how old are you?
I'm 81.
Okay.
I'm 81.
Yeah. So again, this is it's sort of it's the doc's call. Um, and it's also the doc's call what they put you on. I mean, we've got somebody else right now who some issues with abiraterone, and they took him off the abiraterone, and the doc says, well, I can't put you on anything else because it's off label. But in fact, some of the docs will do it. So there's a lot of wiggle room. I think some of it is how much treatment you want to do. So you heard from Sam, he got on fine with it. Other people will tell you they don't get on fine with it, but that's why we'd like you to be talking to people and giving you all the options. I mean, if I was sitting there, if I was sitting in Penson's shoes and I wanted to claim that I could treat people with recurrent prostate cancer, I would be saying you can do this, that, or the other, and you decide. I wouldn't be deciding for you. But
Sam, how long were you on the drug?
How long was I on the drug? I was on it for a year.
1 year?
Yes. And since that time, my PSA has been undetectable on quarterly monitoring. And right now, it's my latest PSA done in July was it was 0.1. Less than, I should say less than 0.1.
So you don't have to go back on the drug as long as it stays low?
Yeah, that's just, yeah. My urologic oncologist indicated that he feels that intermittent therapy will be the way to go. If my PSA gets to 1, I'll go on treatment and then for a period of time and then stop it once my PSA drops down to undetectable.
So I'd like to move on because we want to talk to Victor, and I have some notes on Victor.
I can present Victor if you need me to.
Yeah, no, maybe I know that he was trying to get he had an appointment to see Dr. Appelman, so that's maybe where we are. And this comes from this. I think Victor.
I'm still on.
Yeah, Victor, I think we did do an intake on you in here. I seem to remember that, but we'll go to you next anyway.
Okay.
And we'll let Dr. John whistle through where you are, and then you'll bring us up to date. But any other questions for you, Jim, before we move on?
Not at this point, no.
No. That's
So you've got some options, Jim. You've got Schaefer and Kirshner in Nashville. You've got Collins and Guanciale in Bradenton. You've got some pros and cons for your how much treatment to do, but I think that's the sort of direction you're going to get from from Schaefer or from Guanciale, and the jury's out on Penson. Although I think we would all agree that he made a good suggestion with the Orgovix. So, okay, over to you, Dr. John, to talk about Victor, and then Victor, please update us on how you're doing with Leonard Appelman.
Okay, Victor, please correct any missing or incorrect data here. Victor Ciclari is a 63-year-old Pennsylvanian diagnosed in 2019 when his PSA went up to around 4. He had an MRI with a PIRADS-5 lesion. However, when biopsied, he had only a Gleason 3.3, so was put on active surveillance. Did quite well on it for many years. I have a record of a Prolaris low-risk test, which I think was in 2023. I don't know why that was done, but the PSA popped up to 10 in December of 2024. He ended up with a radical prostatectomy in May of 2025, and his Gleason score was updated to 3+4. It was read as 25% of the tumor was Gleason 4 pathology. The pathology was bilateral and negative for cribriform ECE, but it was positive for PNI, bladder neck invasion, and positive margins. If I got this right, only one lymph node was sampled, and it turned out to be positive.
No, negative.
Negative? Okay, well that fixes up a discrepancy that I had. He's being treated at UPMC by Applebaum. I forgot what it was. What?
Appelman.
Appelman. Okay. He's not a vet. His post-op 6-week PSA was 0.06, and so I am very eager to hear what his 12-week post-op PSA was, if he's gotten it yet. And that's my presentation.
So
Thank you, Dr. John.
Okay. So I'll make one correction. The Prolaris was done in June of 2024, and it was a 3.4 as an additional data point on the active surveillance. But then the PSA rose from at that point, maybe it was 8 something to over 10. So that's when I got into the high risk scenario and considered surgery. So just to follow up, I have not had a subsequent PSA test. I will be doing that shortly. So I met with Dr. Appelman a couple of weeks ago. I have yet to have a second meeting with my surgeon. That is scheduled for Friday. Just to fill in a little bit of blanks, when I got the pathology report and the surgeon did not appear to have read it, because I pointed out that there was some cancer there, and he was a little bit dismissive that he felt that there were clean margins, and sometimes the pathology report isn't always correct. So that really surprised me, and that was when I came to this group for some advice, and I was given the recommendation to see Dr. Appelman, which I did. So Dr. Appelman went through my history. He confirmed what I thought would be the next step, which would be to monitor the PSA and see where it goes. What Dr. Appelman said is, let's do another PSA in a couple of weeks just to see where things are, given that sometimes a PSA can drop, sometimes it can go up. Obviously, it's not undetectable, which is where we would want to be, but it's not there yet. So his recommendation is if it starts to get up to 8 or 9, 0.08 or 0.09, we should consider radiation and ADT because the two protocols together early on has better percentage of success than waiting and keeping it under surveillance. When I initially talked to my surgeon after the surgery and raised the cancer pathology report, he was very vague about what the protocol should be, other than to say point two would be the determination of whether we did salvage radiation or active. So I didn't get a sense that he really knew a lot on that. So basically, I'm going to continue to surveil and see what happens. That's pretty much it at this point.
So my big concern, Victor, based on a gent who we have supported for 4 or 5 years, who had activity in the bladder neck and he did not attend to it early, and then it presented some issues later on, is really around that what they found in the bladder neck. Did they confirm what they found in the bladder neck had prostate cancer in it?
They did. The pathology report. So we haven't done any subsequent, like a PSMA PET scan. Dr. Appelman thought it, with the level that I had, it would most likely present a false positive and may not really be very helpful. So he didn't think it was really going to be helpful given my situation. But the pathology report, what it said specifically, just give me a second here, is that it said carcinoma extends to the left anterior bladder neck and left anterior prostate resection margins.
Just read that one more time for me, please.
Carcinoma extends to the left anterior bladder neck and left anterior prostate resection margin.
Okay.
So real invasion is identified.
Here's what I'm going to do as step one from our standpoint. I'm sending to you right now the email address for Jeremy Liu, who we haven't seen in a while, but he is pretty much a regular. He's a really, really good guy. He had a very similar situation to yours. He's savvy, and send him an email. Tell him that AnCan connected you to him, and set up a time to speak to him and see what he thinks. And I'd like you to put that into the hopper, and then next time you speak to Dr. Appelman, it might prove very helpful for you.
Okay.
So I just sent it to you. It'll be in your chat window. I know you're on the phone, so I'm not sure how you get to it, but it'll be there. If you don't find it, just send me a note, rd@ancan.org.
No, I have.
Oh, yeah.
Thank you.
Okay. So, yeah, reach out. Anybody else have anything that they would like to review with Victor about this bladder neck situation? I don't see any hands going up. Dr. John?
I don't really see a strong need for a PSMA scan at the present time. I think I would like to see that next PSA, which is due now. Because we know that the surgery didn't get everything, it would not be surprising if the PSA did not drop down to non-detectable. You might have to be like pretty much everyone else in this room and get some treatment if it doesn't. But right now, I think you're good for the present moment.
I did have one question for the group. I learned recently that my daughter is pregnant and I'm going to be a grandfather.
Oh, so, congratulations.
Thank you. But that presents a little bit of a challenge because if I go for radiation and it's probably 4 to 6 weeks, I believe I'm not supposed to be exposed or near any pregnant women or children, infants. Is that correct?
You know, it's the case if you have brachytherapy, if you have low dose brachytherapy. If you have regular, when I say regular, if you have external beam therapy, I'm not sure. Who knows about external beam therapy and pregnant women?
Radiation does not stay in the body. It kills the cells and it is gone after the treatment.
Agree.
That's really good to know.
Okay, so there you go.
Thank you.
That's what I thought, but I didn't want to assert it. I don't have the courage of my convictions like Jeff Marchi does. So
I've looked it up recently.
oh, you looked it up, okay. But if Dr. John endorses it, we're good. So there you go. Okay.
I would just say that you should probably check, because I know for my Pluvicto treatment,
That's different. That's
the
very
amount
different.
of radiation I receive is significant,
Yeah.
and that's quite different.
Stan,
So it just may pay to just check.
Pluvicto is very different. It's not.
No, I know that.
It's not the same. It's not. That's what I said. External beam radiation. If you have brachytherapy, if you have Pluvicto, that's a whole different story. And you're right. Then you're in a different ball game. But external beam is what we're talking about here. All right, we're gonna start running down some of these people. How many people do we have? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Oh my gosh. Okay, we better get going quickly here. Richard Craymond, you're up first because you were on early on.
Okay, I will turn that back on. Just an update that after the last PSMA PET scan, found that the lymph nodes are growing and they are now hot. Actually, in the iliac and actually going up the spine. I don't remember what all the names of the lymph nodes are there. The interesting thing is the nodes in the lungs are still stable. They're not growing. They're nice and they're not hot at all. So with that, I've been seeing Dr. Tobias Chapman, and we're going to be going on to Pluvicto to attack what's attacking the lymph nodes. And that's kind of where we are. And I think they're going to schedule that, the start of that this week.
Where is Dr. Chapman? Is he at one of the centers of excellence, or is he at your what's it called in
Innova?
Innova? Thank you. Is he in Innova, Doc?
Yeah.
Look, here's my big concern, and I think that I would want to run this down before I started Pluvicto. We would like to try and find out if there is any record of treating foamy gland with lutetium 177, lutetium 177 PSMA 617.
Basically, from Chapman, he has not found any. He went looking for it. And
did he reach out to Novartis?
Yes.
Okay.
I
And Novartis.
I don't know specifically what the conversation was, but he did that before recommending Pluvicto.
Okay, so he's definitely spoken. What about your other docs that were involved? I'm just trying to remember.
Allen, Josh Allen, and
Markowski.
Markowski both have recommended the same thing.
Okay. Okay, well.
And I guess the bottom line is there's no history to say what the answer is, but basically going after the lymph node growth now, and
Okay.
not and leaving, and I'm still on the Eligard and ADT for, and that's controlling the lungs.
Okay, and you're not on a second doublet therapy, I guess, because probably it's not driven by testosterone.
Right, and the other issue is Abby gave me a lot of side effects, particularly
Okay.
my neuropathy is now becoming a major issue to the point that I'm going to the Johns Hopkins neuropathy clinic for that. They actually treat neuropathy brought on by the chemotherapy.
Yeah.
But I went through 20 rounds of the chemo.
Right.
Other than neuropathy, I did well.
Yeah. No, the neuropathy is kind of miserable. One little thing I always mention with neuropathy is to supplement with B6. You're not
You're not the only one. All three of the oncologists have said, you're taking B6, right? And also B12 because I was showing a low B12 level.
Well, that B6 worked for me. I can't say it works for everybody, but it hasn't taken it away, but it's certainly improved it. So run down the CVS and get some of those B6 tabs and see if it helps you at all.
I get the
too much B6 can cause neuropathy.
Excuse me, Mr. Marchi.
Too much B6 can cause
Mr. Marchi, I don't want to have to mute you. We're in the middle of a conversation. We'll come to you. Okay? Go ahead.
I was going to say, I buy the B6 by the large jar.
Yes. Okay. Go ahead, Jeff.
And but the other thing the neurologist came up with is turmeric.
Yes.
For more for the inflammation.
Okay, go ahead, Jeff.
B6 can cause peripheral neuropathy, particularly at high doses. High doses of B6 can lead to tingling, burning, or numbness, usually in the hands and feet.
Right.
But we're not get the right dosage.
Yeah, we're not talking about that level of dosage and everything. I take 100 milligrams a day, one big tablet. You can take a little more than that, but just get the dosage right. But don't be popping a whole lot of it. So,
100 milligrams a day.
That's what I take. I
And
take
that's what I was told to take.
Yeah, that's what I take, and it works. So, Jim Marshall, you have your hand up.
Question, Richard, where is it at? Okay, in the legs or the feet or where?
Legs, feet, hands.
Okay, for the legs, I wear compression socks, and that helps in the legs. I don't know about hands or thing, but as I say, compression socks are amazing.
Yeah, I've got those. To tell you the truth, I don't like putting them on.
Well, that's the hard part.
Yeah, that is the hard
After
part.
they're on, they
Yeah,
work.
They are.
I've got to admit, the other part of this is, and neurologist has actually given me a referral to the pain clinic there, and I haven't really taken it because, yeah, the neuropathy is a, pardon the pun, pain in the ass, but it has not been that painful. You get the tingling, the all the numbness, things like this. But that has not, the carpal tunnel syndrome has bothered me more. And
So,
I'm on cortisone every 4 months now for that. That's working.
right. So we've really got to move on because we've got a lot of people that need
That's all
time.
I had to say.
Thanks a lot, and we'll come in and check. Dr. John, you have your hand up.
Can I say one last thing before Dr.
Go
John?
ahead.
And that is, it has actually been very helpful to listen to the people, the guys on this program on what to expect with Pluvicto. When I started this, Pluvicto was advertised as being the last step before hospice. Now it isn't.
No.
Right.
My comment was that B6 can sometimes be found in a number of other products, like multivitamins and other products. So just make sure you're not taking more than you think you're taking, please.
I've been warned by Dr. Allen not to take the multiple vitamins because you're never quite sure
whether you need them or not. That's good. That's good advice. Stay away from the multis and take what you need. That's great advice. The other thing is, if they've referred you to the pain clinic, try and get them on your team. That's like palliative care. You can use them. You should have a palliative care or a symptom management doc on your team. And with that, I've got to move on to the next guy.
Okay.
So, Mr. Valens, you're up.
Oh, I'll just quick update. I'm still on my first cycle of cabazitaxel and carboplatin. Haven't really seen anything happen from that. I'm not getting better. And I talked to Dr. Agarwal tomorrow because I've not seen the result yet of my last biopsy. They sent out for new tests. Genetic tests and checking for DLL3 because I might qualify for a trial that Dr. Agarwal is doing. But what I don't think I'm going to qualify from what I've been able to read so far. And the strange thing for me is I've never had a PSA over of 1 or 1.1 until it started going up about 2 months ago, and now I'm over 12, and never seen anything like that before. But my doctor's just saying just the chemo is really all we can do about that. So I'll have more information next week after I talk to Dr. Agwell tomorrow, and the plan is to go through a second cycle, so that's another 3 weeks, and then do some new scans and see what we see.
So, did you get anything back from Dr. Zhao on whether he saw any small cell?
I've not heard anything from him.
Okay, well, give him a nudge.
I need to.
Send him an email and give him a nudge. And as I am showing here, the Tempest report showed absolutely nothing from the biopsy. Nothing actionable, correct?
I haven't seen anything about the Tempest.
Oh, I thought you. So has Tempest come back yet?
Not that I know of.
Okay, well, they should have done. So again, I would be following up on that. You can even call Tempest. Call their.
Dr. Agrawal wants he has most faith in the UCSF labs, and so I think I'll learn tomorrow what they say, and then I'll follow up with Dr. Shao and with Tempest.
Okay.
Where did the tissue? I was just wondering where the tissue came from that Dr. Zhao was looking at.
Liver metastasis.
Thank you.
And not to be rude, I may have to leave early. My nephew's coming from out of state for a few hours, so when he shows up, I'll have to disappear. But
oh yeah, by all means. By all means. I think. Oh yeah, that's okay. All right, my bad. All right, let's move on. And the next person is John G. Go ahead, John.
Hey everyone. Just status. Same thing. I'm going to have my PSA tested next week, so I won't talk to you guys until then. I was Gleason 9. I'm very worried what it's going to come back. It was low when they tested it after the radiation, 0.03, but I'm very concerned. I'm just struggling to figure out what kind of questions I should ask. I'm not sure there's going to be a medical oncologist. I'm going to meet with the radiation oncologist. They're going to do another round of Eligard, and I think I'm going to meet with the APRN. I'm just struggling with what questions to ask. And there's a new medical oncologist at Moffitt, and I was wondering if anybody knew anything about him. His name is Jingsong Zhang, Zhang. I think he's a GU oncologist, a medical oncologist, but I'm not absolutely sure. So that's it. I have other bad news. My cousin just passed, and she had cancer, so I'm kind of struggling with that too. And I'm just showing up here and listening and trying to learn and figure out what's coming next. So if anybody has any, I don't know. I'm just going to ask them. Oh, I don't know. I guess it depends on what the PSA comes back. So anyway, I appreciate everyone.
So I would say just a couple of things to begin with. Zhang is not new from memory. I'm trying to find my list of Moffitt, but I'm pretty certain that Moffitt's been here. It is. Moffitt's been there
He's been there. Yeah.
He's been there a good while. From what he's been there at least 4 or 5 years. I've seen him, so I wouldn't say he's a new, but he is a GU medical oncologist. If that's and he's also the interim vice chief of the department, so he's been around a good while. we're all sorry to hear about your cousin, and it throws you for a loop, especially when you're dealing with stuff. But I want to read to you what I have on my desk in front of me. I'm going to have to put my light on here because of my old eyes, but it says it's from a Chinese scholar called Liao Tzu, TZU. It says, if you're depressed, you're living in the past. If you're anxious, you're living in the future. If you're at peace, you're living in the present. And I think that the best advice we can give you is, as best as you can, to stay in the present. You don't know if your treatment has been successful or not. We hope it has. But just try and stay with us, stay in the present. And with that, I want to ask for the input from my co-moderator, Len.
Perfect advice, Rich, quoting Lao Tzu there.
Yeah,
Lao Tzu, yeah. He's kind of the founder of the Tao, the way, Zen Buddhist philosophy. And yes, just stay in the present moment, John, as much as you can, as Rick said in that quote. If you're thinking about the past or worried about the future, you're not present, and the present moment is all we have. So just keep reminding yourself to stay in the present moment.
I just want to add one thing. I write poetry, so I was composing all these poems for her, trying to perfect them and get them all perfect so she could, her kid could read them to her. But then she passed, and I never got to send the poetry. So talk about being in the moment. What we have is right now, and even if it's not perfect, communicate what's in your heart. I mean, I don't know, I'm sounding
Right.
weird.
No, you're not sounding weird. But I have to ask you, how come you weren't in our creative writing class this past week?
I think I might join it. So
I think you should join it. And let me just say that next week, just a little heads up, this will be on the 28th. No, the 27th, and it will be quite late for those of you on the East Coast, but it will be recorded. We are going to be talking to John Maxwell. I'm going to be interviewing John Maxwell, who's a published poet. I think his book's called Hammering Nails. His anthology of poetry is talking about hammering nails. Many of you know John Maxwell from this group, and we're going to be interviewing him. So, John Graff, I expect to see you there. And I do I have not been to the creative writing class previously, but I wrote, as you probably saw, I wrote a couple of pieces for this for this session, and it was great. I love being there. It was really good. So some of you
try. It's going to be the day. It's going to be the day after my PSMA. Somebody coming here from Tampa, but I'm going to try to make it if I can.
If you can, we'd love to see you.
Thanks, everyone.
We'd love to see you. Okay. Anything else for John before I move on? Okay. Next up is Tony Fig.
Hi. 2 years ago, I had radiation therapy in the pelvic bed, and since then I've been in a remission. And recently I just started having blood in my urine, and with a urine test and blood test, there's no infection or anything, and the doctor's thinking that it's radiation, hematuria, cystitis, and I'm going to be having a cystoscope done on a Thursday. And there's been one instance where there was quite a tremendous amount of blood that came out. But other than that one time, it's just been traces every day when I urinate. So I'm not sure. I don't remember us talking much about that type of radiation. side effects. So I was wondering what I might ask the doctor or look at, and what kind of treatments do they have for that?
So we actually have talked about radiation cystitis quite a bit in this group, and radiation proctitis. And I would say, without checking first, that if you went and searched on our website for cystitis or proctitis, you'd find a whole bunch of groups where we've spoken about it. I had both. Neither started that quickly, probably about 2 to 3 years afterwards. The cystitis happened quite a few times, and in the end, my doc said to me, "Look, if it happens one more time, you've got to come in and you've got to get a scope, cystoscopy." So they went up, and it was the cystoscopy was a nothing. It sounds a lot worse than it is, and they saw a little bit of irritation. That cleared up. The proctitis has never cleared up, but it doesn't bother me very much. It doesn't bother me at all. Now, some of us have had treatment for the cystitis. We've had laser ablation and other treatments. Also, the hyperbaric chamber. So I would like to throw it open to people who might have been treated for etheritis. How about this? Etheritis. If you've had etheritis, then put your hand up, please, and we'll go to you, and you can give some comfort to Tony Fig. And if I don't see a hand, I'm going to pick up people.
I had a cystoscope 6 months ago, and that was clear. I thought I had a stricture.
Okay, so who's going to talk about itis, or am I going to ask Len to start it off? Len?
Sorry, I had to step away for a second. Well, I had proctitis, as you did, Rick, and that's not Tony Fig's problem. So I'm not sure my comments are.
No, he asked for both proctitis and cystitis.
Oh, did he? I'm sorry then. Okay, so I had what do they call it? Argon plasma therapy, which is a type of cauterization. Tony, it's basically like a colonoscopy. You prepare for a colonoscopy. They, insert this device into your rectum, and just like with the colonoscopy, it has a camera. They see where the areas are of inflammation and bleeding in the rectum, and they cauterize it. I had to have it done twice. The first time, the GI doc said, "I'm deliberately going to go very gentle because, it's better if you undertreat than overtreat." So first time there was maybe a 10% improvement. Second time, about a month later, we did it again, and ever since then, I've been like 90% free. The reason I still have some bleeding, it's mostly from the anus, because they cannot treat the anus. For some reason, if they cauterize the anus, you wind up with chronic diarrhea. So I was very happy that they didn't do that. But it's what I have now is not a concern at all.
Thanks, Len. Anyone else want to comment on the treatment of cystitis or proctitis before we go back to Tony? Yes, we got Dr. John. Go ahead, Dr. John.
I have the same thing, Tony. It like Rick, it started a couple of years after my treatment. Maybe I would say 6 times a month. I either pee out clots or what looks like a whole toilet bowl full of blood, but of course it's not. It only takes a little bit of blood to make the whole toilet bowl look like it's full of blood. Follow your hematocrit to make sure that you don't lose too much blood, but probably you won't. And also have your urologist, they're already thinking about this, make sure that the blood is not coming from the kidneys, which is very unlikely, but is a possibility that has to be ruled out. Treatment is not so easy, I don't think. I think that, if the treatment of hyperbaric oxygen therapy is a real pain because you have to go practically every day for weeks and weeks and sit in the little MRI machine thingy. So what most of us do is we just wait it out, and several months goes by and it eases up.
Exactly. Tony.
What happens is that damaging the wall of the bladder? Is this what the source usually is?
Yes, the wall of the bladder is inflamed. You'll get to actually, if you choose to, be able to see it on the screen when you get your procedure.
Okay. Okay, I appreciate your input on it, guys.
Peter Monaco. Peter Monaco, you put your hand up.
Sorry about that. I had a question for Tony. I experienced hematoras in the past, and I also had radiation about 10 years ago. But I'm also on a blood thinner, and my oncologist thought that was the culprit, and it turned out it was. I'm assuming you're not on a blood thinner like Eliquis or Xarelto?
Yes, I'm on Eliquis because I'm in 100% AFib, non-symptomatic, and also I had a tricuspid heart valve replaced, so I have to be on that, on the blood thinner.
Yeah, that could be a cause for the hematoras, possible.
Well, I've been on Eliquis for 4 years, so that was before the radiation treatment.
Okay. So it's not
That's
that.
a good question, though.
It's
Just
a great
curious.
suggestion, Peter. And definitely I would raise it with your docs and just say, I'm on Eliquis. So they know. I mean, I think the problem is that when you are on a thinner, even if it's something as simple as an aspirin, you just tend to bleed a lot more. When something bleeds, it bleeds a heck of a lot more. So, that could be. Now, nobody's saying come off the Eliquis, but it might be a bit of a wild goose chase doing anything else, because it could be like in Peter's case, it might be down to the fact that, your blood is thin.
Mm.
Yeah, what I did was I went off the Eliquis for a couple of days, and the bleeding stopped actually within a day or so. But my oncologist said stay off it for 3 days or 2 full days after the bleeding stopped, which is what I did. And it happened a couple of times, and each time that protocol stopped it.
Okay, I'm watching my time here, and I got to keep moving along. Sorry to rush everybody through today, but we got a lot of people that wanted time. So if there's nothing else, and I don't see any hands up, we're going to go to Ed. Ed, what's going on with you, sir?
Just a little update. Going for my 4th Firmagon shot next week, and I start my first session of 38 sessions of radiation on Wednesday.
Okay.
So, any hints for radiation I should look out for?
Well, the one thing, I guess we should probably just say that this is initial radiation, correct? Because you were diagnosed. I'm doing this from memory, but you were diagnosed de novo metastatic, right?
Yes.
Yeah. So, oh no, wait a minute. No, I'm wrong. You had no, this is recurrence.
It's a recurrence, yeah.
This is recurrence. So this is recurrence, and so this is salvage. This is salvage radiation that you're going to be getting, correct?
Yes.
Okay, my bad. I should have pulled you up first. So the one thing that certainly helped me was to make sure I did a little bit of exercise every day, and I walked at least, 20 to 30 minutes. It does definitely help, because when they're radiating the pelvis, you do feel pretty fatigued from it, because it's nailing a bunch of stuff in the bone marrow.
Yeah.
So that would be mine. The other thing is your diet. You might want to adjust your diet, and instead of eating all the stuff we're supposed to eat, like high fiber and veggies and brown rice and brown this and brown that, you might want to just go on a temporary white diet whilst you're doing the radiation, because it is easier on your gut only whilst you're doing the radiation. So if you like that white bread, now's the time to eat it. Anybody else want to add anything?
Well, for the first simulation I had, I failed because my bladder was full enough, but my bowel was too full. So I met with the dietitian, and that's what she said. My wife and I, our diet is, a lot of nuts and whole wheats and stuff, nothing processed, homemade stuff. And she said, well, you got to cut that out and cut out the fiber a lot.
Only for the radiation. I hope she said only during radiation.
Yeah,
she did.
She said on Fridays you can have your fiber, but then after that, cut it off until the next Friday.
Yes. So yes. So eat well, and then eat all that stuff that you're not supposed to eat, that you want to eat, and enjoy. Len Sierra.
Right. So, Ed, I've heard, and maybe you guys can confirm this, that while you're undergoing radiation, you do not want to be taking any antioxidants.
Yes.
Because that'll work against the radiation.
Very good.
Antioxidants such as?
Well, there's so many antioxidants. I don't know. I mean, some of them are in, supplement form. Who is going to suggest, who can list some of the antioxidants for me without me having to look them up?
Well, are you guys just talking about supplements? Because it'd be pretty hard to avoid antioxidants in food. You'd have to skip all your vegetables and half your fruits. And do you mean supplements?
That's what I heard. Yeah, supplements like omega-3 fatty acid.
There you go.
That sort of thing.
Yeah. So that should be easy to avoid.
But as far as vegetables go, I mean, as Rick said, you should be on a bland diet during the radiation, so you don't really want to be eating vegetables, or you want to keep your fiber very low.
Yep, that's what the dietitian had said.
Yeah.
Yeah, and if you're taking any supplements and you're not sure, just check them out and see if they're an antioxidant. And Len's suggestion is a very solid one. Easy on the antioxidants. Now, I did recently read, and I think I put it in this week's reminder, that resveratrol, which a lot of people like to say is an antioxidant and the reason why red wine is good for you, you basically would have to drink 100 liters of red wine for the resveratrol to make any difference. So, that's going to put you under the table. So what I would say is, don't worry too much about the antioxidants in the red wine for the time being. Who else has their hand up here?
Thomas.
Thomas, go ahead, Thomas.
Yeah, I've just got something out of a reference I have here. Antioxidant supplements, vitamins A, C, and E, coenzyme Q10, N-acetylcysteine, NAC, should be avoided in patients with cancer. In an experimental model, Wang et al. Demonstrated that vitamin C, E, NAC increased tumor angiogenesis by BAC1 mechanism. These antioxidants should specifically be avoided by patients undergoing chemotherapy and radiotherapy. And the last thing here is while vitamin C is a potent antioxidant in the oral pathway, the intravenous vitamin C is not so. And that's something you can all check on. That's it. That's all I've got.
Okay.
Thank you.
Thank you. All right. Anything else for Ed before we keep running through? Next up is our old friend Vic, who we haven't heard from in this group for quite a while. What's going on, Vic? You still with us, Vic? It looks like he may have dropped off. So just before we go any further, is there anybody else who needs to drop off before I get to him? All right. Well, let me know if that's gonna happen. I'm sorry that we didn't get to Vic P, and maybe he'll come back. Maybe he'll be back. So let's. What was that? You, Jim Marshall? Did you want to say something?
Yeah. Excuse me, Rick. It shows that Victor's on.
No, that's a different Victor. There's two Victors. Yes.
Okay.
Yes, that's the Victor we spoke to earlier on, and this is the Victor with the lovely Italian last name, who Pagliasotti. So what does that mean? What does that mean, Len? What does Pagliasotti mean?
I think paglia is hay, like hay.
Yes. Haymaker. Hay cutter. I don't know.
All right. I think is under. I don't know. I'm not sure.
Okay. Oh, he sleeps under hay, maybe. I don't know. Vic, if you're listening to the group, we're sorry that you're not here to talk to us. And with that, we'll go to Dan in Alexandria. I can see you, Dan. Can we hear you? No, we can't hear you. Your microphone's not working. Sorry. I can see your mouth moving and it's white, but it's not. Make sure you got the right microphone selected on the settings in the top right. That cogwheel, you got to pick that headset microphone. So,
any better?
Yes, now we can hear you. There you go.
Sorry about that. Sorry for the delay.
Okay. That's okay.
I was de novo last year, did the radiation therapy last year and hormone therapy for about a year and a little bit more. My PSA remains insignificant at 0.01, and I'm meeting with my urologist next month to possibly take a holiday. That's number one. Number two, I also did a CTX and it came out at 688, which is a little bit lower than the previous one. We were talking about this. The previous reading was 743. It indicates bone problems. And the third issue was osteoporosis. I know people were talking about that earlier. I've been taking supplements, turmeric and ginger root, and also hyaluronic acid, which has really been helpful. And that's all I have to report.
So wait a minute, that was a lot. So you've been taking turmeric, and what else for your bones?
Not for the osteoporosis.
Well, for the
Yeah, for the
osteoporosis, that's for your bones, in my view. But go ahead.
right
Turmeric
turmeric, ginger root,
and
and
ginger root.
hyaluronic acid.
Oh, I don't know about hyaluronic acid, but I know
It's
I know.
good for joints.
Okay. But I mean, I was osteoporotic, and I took I had some Zometa, zoledronic acid for it, and it
Right.
seemed to work at the time, but it's sort of gone back.
I did the reclass shot,
Right.
and I'm meeting with my endocrinologist next week about that. We're going to look at that same issue that we're currently talking about.
So you said CXT. I don't know the CXT measurements. Have you been doing DEXA scans?
Yes, previous to that, they did a DEXA scan.
And what was your original DEXA scan reading that led them to?
I think it was minus 3.3.
Ooh.
Minus 1.5. That's why they put me on reclassed.
Yes. And where was the 3.3? Was that your spine or your hip that they were seeing?
In the spine.
Okay. Well, yes, that's and have you had another DEXA scan to see the improvement, or you're doing it off this? Did you call it CXT?
Yes, the CTX, which is the collagen crosslinks.
Okay.
And we'll talk about that next week. And then just while we're talking here, she just emailed me and said, maybe we ought to do another bone scan. I'm a little reluctant for that, but we'll see what she says.
Now, a bone scan or a DEXA scan?
She said it's not a DEXA scan. She'd rather go to the bone scan, but I already have some information I just sent her on that.
Okay, well, I would say when was that 3.3 in the spine?
4 or 5 months ago.
Okay, so yeah, probably good to wait a while to do another DEXA.
Yeah, and that's why I'm reporting now, because I had serious side effects from Abby and prednisone at the beginning of the year, which started all this rigmarole for me for the last 5 or 6 months, which brought up the CT scans, etc. And so I think the current regimen that I'm on is a little bit better, but the data is still out there to be evaluated.
And just since Dr. John's been kind enough to put the normal range in the chat window, what is your CTX measurement?
It's 688, which is down from 743.
Okay.
Still losing bone, though, I would guess.
Absolutely.
So
that's why she
this
ahead.
deserves aggressive treatment.
I'm sorry I didn't follow, John. Dr. John.
I think it deserves ongoing aggressive treatment.
Mm-hmm. In addition to the reclassed.
Well, I don't know. That's what I would like to see what the endocrinologist says. That may be sufficient, but something strong, you know.
Right. And the reclass is a little weaker. We all talked about this a couple meetings ago. It's a little weaker than the Zometa or the other one that Rick just mentioned, the shot.
I kind of think that the monoclonal antibodies are stronger than the bisphosphonates. I think Rick, who knows a lot about this, may not agree with that, but let's see what the endocrinologist says and make sure you get the strongest treatment you can tolerate.
Great.
I completely agree with you, John. The problem is that Kaiser doesn't like to give the denosumab because it's more expensive.
Correct.
you know, you should be on Xgeva or Prolia, which is the denosumab, but they push the zoledronic acid on you because it favors their pocket. But yes, you need them, and hopefully it'll keep coming down. The other thing is to be doing the right sort of exercises. I mean, I was doing a lot of squats with with a bar on my shoulders. I mean, I didn't have a whole heck of a lot of weight on the bar, but that's what I was doing. I was also a lot younger than I am now, so. But I mean, that's the sort of thing, because to exercise to stress your spine, which is what you need to do if you're that low, that negative in your spine, is not easy. I mean, to find exercises to do that will stress your spine, which is what you want to be doing, is tricky, and you should be doing it under supervision.
The endocrinologist does agree with that idea, that, and I'd like to see what Len thinks about that the MABs are stronger, then I think you should start a big fight to get them, spearheaded by the endocrinologist.
Will bring up. Thank you.
Yeah, the problem is that I hate to be doing, what's the word I want? Somebody's comforter. Whose comforter is it? The doomsday soothsayer, or Job's comforter. I hate to be Job's comforter, but the damn endocrinologist in the Kaiser system is going to toe the line. That's the problem.
As the urologist does, yes, you're right.
You know, they're just going to toe the line. So
I have been exercising, and it definitely on the weekend, and it's made a big difference along with those supplements I mentioned. So not to get too deep into this, because I know you have other people that want to talk, but thank you for the time here, and I really appreciate it. I will update everybody on when I meet with the endocrinologist next week.
Okay, Len tells me my volume has gone down. I'm sorry if that's the case. GoTo defaults me out of my systems after a while, and I cannot stop it doing that. And then when I come back, it's
still down.
It's still down. I don't really know how to improve the volume. That might help. That I bet that helps. There's a little setting that I need to click as well after they default me. I hope that helps. Sorry about that. Okay. Next up is Barry. Are you there, Barry?
Hey guys, how we doing?
How are you doing on that? How many sessions of chemo have you done now?
I'm in day 4 of round 2. So
okay, and how are you? Tell us how you're doing.
Just starting to fall a little bit into the abyss of fatigue and just general blah. But more familiar with it thanks to you guys about listening to what happens, and so a little bit better prepared for it this time around. And but yeah, I mean, it's what we got to go through. The only question I had that was that I wanted to throw out there is that Dr. Hujic at Minnesota Oncology was talking a little bit about, I'm on that triplet therapy, Rick, that you had recommended we push forward with.
Yep.
And So because of the, he said I have a kind of a positive RB1 gene or something, that at the end of the third round, he would consider using a fourth drug to try to shut down that RB1. I don't know if anybody's been through any of that before or not. So that was my kind of my question about.
Yeah. Well, here's what I would do. Okay, I think I know what's on his mind. And because you got the RB1, I think he's talking about introducing a platinum chemo, carboplatin. I would want to get the opinion of Dr. Heath or Dr. Antanarakis. I would not, frankly, trust the doctor in Minnesota Oncology to make that decision. If it were me, I would absolutely not do that without the blessing of either Dr. Heath or Dr. Antanarakis. And
Okay.
probably, if you were going to, if it was either or, as much as I love Dr. Heath, I think Dr. Antanarakis is more experienced in addressing aggressive variant prostate cancer, which is what he's saying. What do my other guys, what do my mods have to say on that one?
I think RB1 maybe can be treated with carboplatin. I've heard that as well. I hate to blitz the poor guy, but I've heard the same thing. And the wild type, I think, encourages androgen receptor activity, if I remember right.
I mean, I'm not don't get me wrong. I'm not saying it's a bad decision. I'm just saying that I would want a really good GU medical oncologist to confirm it before doing it.
Yeah. Well, Anton Rocca said that I could come back, and Dr. Heath both said I could come back and talk to him anytime an issue like this came up. So I appreciate all that input.
Perfect issue for both of them. What's this guy's name again? I don't have a note of it. The guy that Minnesota Oncology.
Hugek.
Hugek.
Yeah, you.
So yeah, I mean, sorry, I'm just making notes here. I mean, I don't think it's a. I think it's a problem. It's a solid creative suggestion. But I'd love to know what people who have probably seen a bit more of RB1 and P10 and TP53, whether that they think that these mutations warrant adding a platinum, and I'm suspecting it's a platinum that he wants to add. Have you had any testing done since you started? Do you know how this is going?
No, they. I go in September back to Mayo for my next scans and for genetic counseling and a cystoscopy. All of that's in September.
Okay, so a couple of things. Why the cystoscopy?
I don't know. They just Mayo said that they wanted to make sure that. Oh, I had a little bit of blood in my urine.
Have you had any blood in your urine since?
It was it was nothing I could see. It just showed up in my blood test.
Well, I mean, that's
early on.
It's a bit extreme to do a cystoscopy if they just saw a little bit of blood in your urine. Have you spoken to Dr. Heath about that, or is this a Dr. Kwan decision?
Yeah, I don't know who ordered it. I think it was probably Kwan.
Okay. do yourself a favor and check with Dr. Heath whether she thinks you need it.
Okay.
Okay? Because there's no reason to
Sounds
go
good.
through it. And you know, the doctors don't tend to do the cystoscopies unless you've got a persistent problem of blood in your urine. So, you know, there may not be a need to do it, and I would check. What else are they going to do at Mayo, Barry?
More genetic testing and counseling.
Okay, for what?
For that RB1 and any other thing that might, I think they're going to do another round of genetic testing.
Yeah, but I don't know why you need another round just yet. I mean, I get if this is coming from Quan, I'm leery. We know you
Okay.
in on the 20 back in June.
No, that's coming from Heath, Rick.
Oh, this is coming from Heath.
Yeah,
so
Heath set that up.
Heath set up more genetic testing, even though we found you had CHEK2 and RB1, correct?
Yes.
And that was from somatic testing, or was that, yes, that was from somatic testing, wasn't it? How did we find that? Or was that from the germline testing?
Yeah, I did a special test that Quan had ordered, and that result came back. I don't remember the name of it. It was an outside company that did it.
Right. Was it to see if you had something inherited, or was it to see if you had?
Yes.
Okay.
Yeah.
So
for an inherited gene.
It was for inherited gene, and that's what showed the CHEK2 and the RB1 as being inherited?
Yes. Yes.
Okay. So now I think what Dr. Heath is going to do is to check to see what you're making yourself within your own body.
Okay.
And not the inherited. So,
okay.
You know, what you're showing is CHEK2 and RB1 being inherited. Do you have kids?
No.
Okay. Do you have siblings who are alive?
All girls.
May not make a difference. What you want to be talking about with the genetic counselor is what the impact is of this CHEK2 and RB1 on your possible on your siblings.
Okay.
Because those mutations can affect a bunch of different cancers.
Yeah, I have a sister that just came down with a really rare tumor in her stomach. And
Okay.
in fact, her doctors have never seen it before.
Well, again, that might well be related to the CHEK2 or the RB1. Does she know you carry CHEK2 and RB1?
She does now.
She does now. So they ought to be checking, and I can't remember what Len or Dr. John, do you remember what RB1 germline, what that is called? There's a name for it, I think.
Retinoblastoma 1.
Yeah, RB1. There's like TP53 is Lee Fraumeni.
Oh, you mean if you're born with
Yes.
a mutant?
With RB1?
Yes. Let's see.
I always thought that if you had a germline RB1, I don't think those children lived very long. So I'm thinking maybe that the RB1 he has is somatic, not germline.
Could be. Yeah, it could be that Quan did the somatic test, and Dr. Heath wants to do the germline test now. if she said it. It could be the other way around, Barry. But Barry,
Okay.
this is what's important. You have to find this out. You know, you've got to be your own best advocate. You've got to know what they're testing you for. You can put it in, you can send a note in the portal to Mayo and say, I know I have check 2 and RB1. Is that somatic or is that germline? And what tests and what genetic tests am I going to be going through? It may well be, and Len might be right, that the check 2 and RB1 are the somatic, meaning that's what your body made. And now Dr. Heath is saying, I'd like you to do a germline test.
Okay, I'll do that.
Okay, so please follow through and please let us know. The germline is what you inherit, and the somatic is what you make yourself.
Okay, I'll get on that right away.
And
thanks, guys.
How are you doing and feeling with your chemo?
Not too bad. First round was, fairly tough, but like I say, today's the worst day of the second round, and I think I'm doing better today than I was the fourth day of the first round. So I'm
now the $64,000 question, where the rubber meets the road. Are you doing any exercise?
I am.
Good man.
So I have to push through to get it done, but I'm my body says no, and I'm saying yes. So
God bless you.
Yeah.
God bless you. Really think it helps. I wonder if Bob Schwartz is still with us. He'll tell you that it helps. He might have given you a good talking to. Like, yeah, he is there, Bob. I can't see in the picture, but I can see. Oh, here he comes. Here he comes. Didn't exercise help you during chemo, Mr. Schwartz?
Yes, it did, Rick. Exercise is primary. You have to do that.
Yeah.
Thank you. Thank you.
Thanks, Bob.
But I will tell you this. It's difficult. Just don't give up on it. It is difficult, but push yourself.
Yep. That's my mantra.
That's great. And it does make it easier when you hear from other gents. So, all right. Anything else for Barry? Anything else for Barry? Okay, so let me just tell you how many guys I got left. I've got 1, 2, 3, 4. Oh no, Alain just left, so I don't have Alain. Jim McPhee, are you still with us?
On?
Yes.
Yeah.
John McPhee. Sorry, I beg your pardon, John McPhee. My miss. Yes, you were going to give us an up. Did you want time for an update?
Yeah, but I can come back.
Go ahead. No, we got you. You know, you're just as important as everybody else on here. So go ahead.
Okay. I had a PSMA PET scan, and my PSA was up at 23, and it's metastasized, and the part that can't be treated, I guess, is the hilar nodes, left hilar nodes, and periesophageal node. And when I asked about that, he said, if I treat your esophagus with radiation, you're not going to be very happy. So I'm on bicalutamide. Yeah, bicalmutamide. You can say it. Bicalmutamide right now. And I start Zoladex and apalutamide coming up in a week or so.
Okay, well, let me just, I've got some thoughts going on here. So they're saying that it's the paraesophageal. Is that correct?
Yes.
And where was the other one?
Left hilar.
And where, does anybody know where left hilar is, Dr. John?
To the chest.
Yes. Okay.
Yeah, they're both up at the top center. One's on my esophagus and the others are on the bronchial tube.
Okay. So here's something that we're learning. Len has learned a little bit about this too. There's a possibility, and who is it that's diagnosing this? Is it a urologist or a medical oncologist who's giving you this information?
It's a radiation oncologist.
It's a radiation oncologist. This activity in your chest and in your esophagus, it's possible that it is not prostate cancer. And you need to be checking into that. It could possibly be esophageal cancer and can be treated in different ways, because we know that the esophagus produces PSMA. And so we would expect to see the esophagus light up when you do a PSMA scan. But when we're seeing this type of activity in your chest and in your upper chest and in your esophagus, what I would be asking for if I were the patient is for them to biopsy my esophagus and see what they see there before they give me anything. To put you on Zoladex and apalutamide assumes it's prostate cancer. But that's not a good assumption given where we're looking. It could be prostate cancer, but before you start, if it were me, I can't give you advice, but if it were me, I would not be taking Zoladex and apalutamide until I'd clearly established that this was prostate cancer they were seeing. And we've had situations where people have had very high PSAs, up to 80. And in fact, it's been coming from the esophageal cancer. So
And the Zoladex and stuff isn't going to do anything for that.
That's right. So I think you've got to dig down a little bit here. And who is it that's who's prescribing the apalutamide and the Zoladex? Is it the RO, the radonc?
Yeah, it's the only person I see. You guys have got teams. Here you get one guy.
No, that's not true. You can get more.
Okay.
You can. I mean, and we've seen it. We've seen it in Canada. We know you can, especially in Toronto. And which hospital are you being treated at in Toronto?
Princess Margaret.
Okay, so you need to get those Princess Margaret docs. You need to see an esophageal, somebody who specializes in esophageal cancer. And you want to check that you don't have something going on in your esophagus.
Okay.
You know, you've got to go to this radonc and you've got to challenge him and say, look, this could be esophageal cancer. I want a biopsy. I want to know before I start taking this stuff. Let's not jump to conclusions here. Same thing with those hyaline lymph nodes. Let them take a biopsy. Let's make sure that it's esophagus. I mean, you know, you have for a long time, your PSA was pretty low. So this could be something totally unrelated to your prostate. Come back and let us know. But push him, John, please.
Oh, well.
You know, we do have a surgeon in the room. I wonder if Russell's still here, if he has a comment on the biopsy ability of this.
Yeah, I can. Yeah, I'm here. And can you hear me?
Yes, we can.
Well, I just had a PSMA scan and the esophagus lit up on me, but it was diffuse. So that's what I would like to know about the scan. But, you know, I would question whether this is esophageal cancer without symptoms of dysphagia. and whether the scan lit up locally or diffusely. But I mean, it's pretty simple to rule out with an upper endoscopy. You wouldn't biopsy anything unless if you look down and it looked normal, that's it. That would resolve it. But I guess it'd be nice to look and see what the scan showed from the radiologist, uh, saying, yes, it's diffuse uptake. And that's exactly what I had. Or is it localized? Now, if it was localized, then I think there'd be more likely to be an esophageal cancer, but without symptoms at all. And the hyalo lymph nodes would suggest if it's from esophageal cancer, that was pretty well advanced. So anyway, it is, as Rick says, it's easily resolved, but I would like to see what the radiologist thought about the scan.
So let me ask you a question, Dr. Russ. Would you proceed to hormone therapy without doing more investigation?
I would like to know more. Again, I'm not an expert on the PSMA scan, but if it's a diffuse, lights up the entire esophagus, then I don't think we're talking about esophageal cancer. I mean, so, and I would think that the hyalo lymph nodes are more related to the prostate cancer. But yeah, the answer is yes. It needs more investigation. And the upper endoscopy is pretty simple to rule out an esophageal cancer.
Excellent. Yeah. So I don't want to scare you, but it's just that we've seen it before and we need a little more investigation. So
Sure.
just saying. And did Len leave or no, Len's there. Len, what's going on in your situation? Can't hear. Len can't hear.
I just half the time I can't hear you, Rick. Partly my hearing, partly your low volume. But so, John, what was he saying?
He's asking your opinion about whether a um, a lighting up of the esophagus on a PSMA PET scan, and we don't know whether it's focal or diffuse, could be could be esophageal cancer. And as long as the question is open, should he go ahead and proceed with augmented ADT therapy based on the idea that it's a prostate cancer metastasis? Is that your question, Rick?
That was my question, but also I wanted to know how Len was doing because Len was having some esophageal issues as well, and we raised it for Len.
Oh, I see. Okay, yeah, pulmonary actually.
Yeah. So in my case, Rick, I tried to make an appointment with my GI doc for an endoscopy, and he just kind of blew me off. He said, "Well, you were already taking a PPI, pantoprazole, so if I saw anything there, that's what I would do. So, and you're already taking the drug, so there's nothing I would do." So, but anyway, just so we don't confuse, where's the barrier, whoever we're talking about. I never had anything light up in the esophagus.
Okay.
In my case, they were trying to determine the cause of a lung disease called bronchiectasis, and we thought maybe it was possibly due to aspiration of to my camera, aspiration of acid reflux, and So, that's why the GI doc said, well, it doesn't make any sense for me to do an endoscopy on you. So
Okay.
sorry for that detour, but
No, that's fine. That's what I was asking. And I think in John's case, since something is lighting up, like I say, let's try and push him to do a little more investigation.
yeah, I mean, it seems to me to be a good idea to do the endoscopy.
Right. Right. Okay, and I know I'm running over, but we're almost done. We've got Sam, and then we've got Stan F. And so, Sam, what? I know you talked to us a little bit before.
Yeah.
What's on your mind for today?
Well, I forwarded a bunch of information to Dr. John, but by way of, and I'm waiting for Dr. John to get back to me after he talks to some other people, but by way of background, because this is going to fit into the previous conversation, back in July of '78, I had my right middle lobe removed, and because it turned out from pathology that it was metastatic prostate adenocarcinoma, 1.6 centimeter. The lymph node level 11 excision showed metastatic carcinoma in one of three lymph nodes. Lymph node level 4 excision showed nothing. Lymph node level 2 showed nothing. So subsequent to that, my that surgery, my PSA stayed around. Yes.
Sam, we can't do a long total
Oh,
recap tonight. Let me go to Dr. John, who you've sent stuff to. He'll recap for us, and then
Okay.
we can come back to you and see what your questions are. John?
Sure.
Sam has a 14-year history of prostate cancer with several of the complications that you just heard mentioned. And when we took a detailed history last time, we wanted to make sure to rule out any neuroendocrine transformation of the cancer over all this time. So Sam sent me a bunch of MRIs, some pathology reports, and my conclusion is that the whole process is adenocarcinoma, including the metastases in the lungs. I would like to see, if it's still available, the original biopsy report, but I was able to set my mind at ease about small cell transformation, and I feel that we're still dealing with an adenocarcinoma that is hormone sensitive.
Okay. And what questions do you have, Sam, for Dr. John or anybody else?
And this previous conversation is really helpful. My plan is to wait until my oncologist says, okay, your PSA is risen to, and I think we've arbitrarily said to 1. But before I start on hormone therapy again, I'm going to ask for another PSMA to see exactly what is going on in my lung. I'm glad to hear that it is that Dr. John, that you've gone through the information and you're comfortable that it hasn't changed and that it's adenocarcinoma. So that's my plan to get another PSMA if and when my PSA rises to the point where my oncologist wants to reinstitute hormone therapy. I just wondered what comments were about that plan.
That satisfies me. The most recent advancement of disease was 2 years ago when some of these new lung findings appeared. So he's got 2 years since the last clinical advancement and a PSA level right now of non-detectable.
Okay, that's what I was going to ask. So currently undetectable.
Let me modify that. My July 16th PSA was 0.1.
It was less than 0.1.
That's the April one.
Oh, I see. Now it's 0.1.
Yes, sir.
Thank
But
you for the clarification.
interestingly, my testosterone went down from 194 to 164. It kind of surprised me.
And what is the PSA level you've agreed on with your doc?
I believe it's going to be 1.
Okay.
Because I still have my prostate. I just had it radiated.
Okay.
45 doses in 2012.
Okay. Okay. Any other comments on that?
Do you agree with 1?
Yeah, I mean, that's a tough one. It depends how quickly it gets up there. If it creeps up, I think yes, 1 is probably fine. If you go from 0.1 to 0.5, in 2 or 3 months, you might be thinking of getting a PSMA scan sooner. It's got a lot to do with the pattern.
One last question, if I may, please, and I know it's late.
Yeah. Yes.
If I do go back onto hormone therapy, do you guys recommend that as soon as it drops down to undetectable to stop it, or do you think you should continue it for a longer period of time?
Well, we don't recommend because we can't give you the medical advice. Dr. Russ may be able to, or Dr. John, but we can't do that. If it were me and they put me back on, I would go on for as long as my GU medical oncologist suggested I go on for, and then when he comes off, I wouldn't be looking to go on and off like that. That's what I'd be doing if it were me. Take the advice. How about you, Dr. John?
Yep, I agree. No, I wouldn't go off it immediately.
All right, we're going to the very last person who's stuck into the end, which isn't normal. So I'm very happy to see Stan Friedman still with us. How's that Pluvicto doing for you, Mr. Friedman?
Very well, Rick. Very briefly, because I know I'm the last one in the queue. I completed my 3rd treatment end of last week. I've experienced some slightly lower blood cell counts, but nothing that has disturbed any of the oncologists that have looked at it. My PSA continues to decline, although because I've always had a low PSA, it's they take some stock in it, but at least it's declining. It's about a half. It's now at about 0.15, about half of what it was 3 months ago. I have another treatment, in another 6 weeks. I did ask them, Rick, about the question you asked me the last time about changing that 6-week interval. And their take on that was that unless there's a demonstrable or significant difference in the course of treatment, they're prone to stick to the protocol of every 6 weeks. For 6 treatments.
I think my question was more not about the intervals. It was about keeping a few in hand at the keeping a few in your back pocket. Did we really need 6 treatments for you? That was my question.
Oh, okay. Well, at the moment, they've told me I'm going for my 4th. So at the moment, they're not. I don't think they're ready to say, let's hold off and put 2 in the bank.
I would want to. I would. Isn't it McHugh? Isn't your guy McHugh?
Yes, it is. Yes, it is.
I would say after that 4th one, I would specifically say, Dr. McHugh, do you want to hold a couple in reserve?
Okay.
Because right
it's
now,
always worth the question.
Yep, and because right now, God forbid you needed it, it might be hard to get your insurance to we know you can do more than one session, more than one round, but we don't know that insurance will approve it.
Yeah,
Right now,
I
it
understand.
may be that they'll only approve 6. That's going to change. It will change as we get more evidence. But you could be fighting with insurance to get more if you needed them in the future, at least as things stand right now.
Yeah. Okay.
And that's the only reason why. All right, guys. 7:22, not bad, not great, but not too bad. What do you think, Len and Dr. John? Okay.
Good job, Rick. Good job.
Len's still with us. Look at that.
I was just
Did
about to
Dr.
sign
John?
off.
Oh, okay. You made it through to the end. You get a special prize. It looks like Dr. John didn't quite get to the end. Look at that. You outlasted Dr. John, Len. Look at
Oh,
that.
John left. Well, how
Yeah.
about that?
Look. See him smiling there? See that handsome face smiling when he finds out Dr. John left?
Yeah, and he's 3 hours behind me too.
Oh, that's right. He's still on this coast. Oh my gosh. All right, guys, listen. We got through everybody, and
Good night,
those who will
everyone.
see you next week.
Thank you
Good
very
night,
much.
everybody. Good night. Good night.
Thanks,
Thank
Rick.
you.